Welcome to Duke Spine Institute. We're broadcasting our live spine surgery. Our patient has chronic back pain, and she has these two discs that are pretty degenerated. It's the number 2, 3, and 3, 4, and we have to get in there and repair these discs because she's having pain coming from these two discs. I'm going to try 2, 3 first. And first thing I have to do, as I do with every patient, I have to access, meaning get into the disc tear. That's the part of the disc where the pain is coming from. It's the back of the disc. Give me an AP. Now she's got very bad scoliosis, so you can somewhat appreciate that on the lateral view, but you'll see it better on the front back view, which we're about to show you right now. Anyway, if you have questions, feel free to ask me. Look how bad that scoliosis is. So, all right, let's go back to a lateral. I've got to get into the two discs there. It's not easy to do. Sean? Wow. All right. Poor thing has been suffering with pain for a long time. Shot. So I'm going to focus for just a moment on getting into these two discs because it's very, very challenging to do. Now she agreed to do the broadcast shot, but she was worried. She said, "Dr. Duke, I don't want you distracted." You're okay. We're almost there. Give me an AP. So type your questions up. I'll answer them a little bit later, but right now I'm just focusing on getting into her discs so we can repair them. That looks pretty good. Yeah. You can see how twisted the spine is. Go ahead and go lateral. So for those of you who think scoliosis causes pain, it doesn't. Scoliosis itself never causes back pain. What causes the back pain is the same things that cause back pain in other people. It's the disc and the facet joints. Shot? Thanks. You having any pain there? Where? In your back?
Right there where you were.
All right. Well, that's what we expect. That's your bad disc is right there, okay? So you're doing great. Just hang in there. We're almost done. Shot? All right, let's get an AP. So we're right at the back of the 2-3 disc, which is exactly where we want to be, but it's pretty collapsed. She is awake, so she's tightening her muscles up. I can feel it, and it's really hard to get in. All right. Yeah, probably want to be a little bit more lateral.
Take a little deeper, or?
Nope. You're doing great. Hang in there, okay? It's not an easy surgery, as I said. Very, very difficult to do. Sean? You okay? Are you okay? Sean? AP? So I'm coming again to the L2-3, and we still have to get to L3-4. Are you having any pain? You're doing really good. I'm really impressed. So, Sean? All right, AP. She also has osteoporosis. You can look at her bones and see they're not very calcified. They've lost a lot of their bone mineral density. All right, that looks better. Still really challenging. All right. I'm thinking I may need to reposition again. Go back to my old position. Shot. And just not aim so lateral or so medial. Shot. Are you comfortable? Shot. Shot. AP. So again, very challenging because of her anatomy. You're doing great. And once again, I don't really like where we are. It's not terrible, but it's not great. So I'm going to try one more. You're doing great. I apologize that you have to bear with us here, Sean. All right, I can feel the arthritis. There we go, Sean. We're almost done, I promise, Sean. This, on a scale of 1 to 10 for a spine surgeon, is probably a 12. It really goes off the chart. But I think we're going to be okay. I like that much better right there. I like that better. Let me see what I can do. The anatomy is so distorted. Shot. Where do you feel that? AP? Where do you feel that? Is she awake? Where do you feel it?
Say louder. You cannot point to it. Is it in your low back, down your leg?
What'd she say?
In the back, she feels it.
She feels it in the back. All right. I'm going to make one more pass. I actually think my original localization was the right one. Sean? And I changed it. Sean? Because I wasn't happy, but now I think it was the right choice. AP. This, normally L2, 3, 3, 4 is pretty easy to get to, but most patients that I do L2, 3, 3, 4, they don't have this degree of scoliosis, which just makes it a lot more difficult. That is much better. You can see her bone is thin. You okay, Sean? So.
You doing all right? Good.
Sean? Oh yeah, we're in that disc. Sean? You having any discomfort? What'd she say?
What did you say? Not too bad right now.
I want to just do a quick discogram. Verify. Nothing down your leg?
No.
Sean? It's very collapsed. Sean? That hurts. Is that where you get your typical back pain? Is that your typical back pain? Sean? All right, AP. It looks like we're in the
Give us
disc.
a pain score, 1 to 10 on that.
How high did that go? I couldn't really get much out.
Give us a number.
How high did it go?
8.
That looks pretty good. Yeah, we're definitely in the disc.
You got an 8 on one disc.
Huh?
You definitely said an 8.
Yeah. Is that your typical pain? Yeah. Well, how high did it go? 9? Is that where you get your pain? All right, good. That's one of the bad discs. I just tested it. She got a 9 out of 10 concordant. That was L23. Okay, L23. So guys and gals, at L23, the L23 disc, which is one of the ones I thought was painful, she had 9 out of 10. That was the highest it went. You always put the highest, and then it was concordant, which means that's her typical pain. Okay, now I'm going to see if I can get the second disc accessed through the same incision. Here, take that. I'm going to try something before I do that. Take that. Give me the needle. We're going to hold any questions for now until I'm further along. Shot? Alright. This may not I may not be able to get the second disc from this same place. I have to probably go elsewhere. Shot? Yeah, I'm gonna have to come lower. What a difference, huh? Give me some more num-num.
Dr. Duke, in the meantime, why don't we show the audience how it is that the 30 causes of chronic back pain.
I think it's a great idea. Let's play that video while I'm getting this second disc accessed.
Copy that.
Thank you, Henry. I'm Dr. R. Duke Majan with the Duke Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Duke laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Duke plasma rhizotomy of the SI joints offered at Duke Spine or Duke Joint Institute. The fourth most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Duke piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, such as the vertebral bodies, with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Duke Majan. Thanks for joining us. How much time is left on the video?
Oh, we're back.
Oh,
Yeah.
all right, folks. We are in the disc. We verified both discs are painful. You can see all the inflammation going on. Look at that pinkness. That should all be white. We are inside the disc. We're using the laser, and we're using the laser to clean up this inflammation, scar tissue, or herniation. It's called an annular debridement. It is the cornerstone of the Duke laser disc repair. This is our main procedure. It's used to treat disc pain, pain from a disc. That's what this patient has. Now, she had a prior treatment with plasma for her facets, and she came back and said, well, that facet pain is gone, but I've got this deep pain right here. So we looked at her MRI, and we did a special test here where we do at Duke Spine with a X-ray, and we figured out her pain was coming from the L23 and L34 discs. And of course, the discs themselves are degenerated. You can see they're collapsed, but she's got these pieces of herniation stuck in there. I'm taking one out now. And these are very hard. They've been there for a long time, these herniations, and her body has tried to remove them herself over probably the last 30 years, and just not successful at getting rid of the herniation herself. People think they can remove herniations themselves, their bodies will deal with it, but it doesn't work that way. Herniations never go away on their own. They really stay there, and the symptoms will keep coming back as you get active and do stuff, and the symptoms just keep coming back until you get it fixed with the laser surgery here at Duke Spine. Now, she's a very difficult case because of her anatomy, right? She's not a heavy lady. She's a very, very in good shape woman. However, her spine is collapsed, spondylitic, bone spurs, and it's twisted horrifically from scoliosis. And that scoliosis is not causing her pain. It's the herniation here and the inflammation. That's what's causing the pain. You can see the pink inflammatory tissue. Any questions from our audience?
Yes, we have a couple questions. This first one is coming from Ian on YouTube.
I'll take the questions, and then I'd like for you to show the audience how is it that these disc injuries cause so much pain in the back, but also how we fix it with our laser surgery. Yes, I'll take Ian's question.
Ian asks, hi, what
Hi,
would
Ian.
you recommend if a patient is still having back pain, ridiculous symptoms, and weakness, and the lower extremities after a lumbar fusion? Maybe the time frame would be 6 months or more post-op. Is this something that you can something that can still be fixed with your procedures?
Ian, yes, 100% we can fix your back pain. Unfortunately, what you're saying, which is still having these symptoms of back and leg symptoms after a fusion, very common, and it's because, I hate to say this, but it's because the surgeon did not fix everything properly. Now, the fusion itself may be okay, but clearly there's other areas that are causing symptoms right above the fusion or below. And what we do very well at Duke Spine is figure out where your symptoms are coming from. That's what we need to do. And we do that for free. We don't even charge you for it. It's done virtually, so you don't have to come to our office. We do it through the internet. All you got to do is go to our website right now, and there's a free MRI. And all you got to do is click on that. It'll take you to a form that you have to fill out. We need your name and some basic information, email, so we can email you. But what we really need is also your diagnostic imaging, your MRI. So I would talk to your surgeon, tell your surgeon you're still having symptoms, and ask them to get a new MRI. And then once you get that new MRI done, you just fill out our form online, and I will personally meet you myself, and I will diagnose exactly what's wrong and tell you what needs to be done to get rid of your pain. It turns out that the pain is always we can get rid of it every single time. I've never met a patient with back pain that I could not get rid of their back pain, okay? So we just got to identify the source. What's causing it? And you watch the video there, 30 causes of back pain. Well, your surgeon treated, they did a fusion. I don't know how many discs they fused, but let's say they fused one disc. I'm just using that as an example. That means that they fused one disc and 2 facet joints. So they took care of pain that would have been coming from one disc plus 2 facet joints. And that's 3 things. But remember, there's 27 other things that can cause back pain. So my job is figure out what's causing your pain. That's what we did for this lady. And in her case, it turned out that her pain was coming from not just her facet joints, but also her discs. And we had to figure out which discs. And that's why we did some special tests. And we actually figured it all out. And now we just verified that through our surgery. Remember, I think you guys were watching, Berndes? I think you guys were watching the video, but we did a discogram and found out that her pain was coming from these 2 discs. Okay, lay still. We're gonna give you a little more medicine. So you can see the last of the herniation here, right there. That's herniation, and it's stuck there to the annulus. That's the annulus, okay? And the reason it's stuck there is, remember I told you when you get a tear in your annulus, can I start?
Yeah.
And you get a tear, and that tear allows fragments or pieces of herniation to go out through the tear, but the tear is a long passage. It's a long, long passage. And the pieces of herniation are about 2 and 3 millimeters long. Some of them could be 5 millimeters, but the tear is 25 millimeters or 30 millimeters long. So think about it. If the herniations are 5 millimeters and the tear is 30 millimeters, that's a long way for those herniations, to get out and escape from the tear. So a lot of the herniation gets stuck in the tear, and that's what causes the back pain, is those pieces in the tear. And I discovered that. I was the first person in the world to discover it. I was the first person in the world to describe it and talk about it. And we've been talking about it with live stream videos now for about 11 years. But we also published in our papers how the tear has to be debrided because the herniations are stuck in the tear and they're causing inflammation. So, my friend, send us your MRI images, not the report, but the images, and set up a Zoom call with me. Doesn't matter where you are in the world, I'll do it, and we do it for free. We give you a diagnosis for free. So you will know what's wrong, and if you decide you want to come get it fixed, we can fix it for you. Okay? We just need you to come to Duke Spine and get it fixed. Any other questions?
Yes, we have a couple more questions. Next one is coming from Charlie on YouTube, asking, what is the state/level of anesthesia for patients during the approach to the disc? What can a patient, quote, feel during the approach? How deep does the local work?
Great question, Charlie. So anesthesia is a very interesting field of medicine, okay? And when we talk about anesthesia, we're talking about basically putting patients to sleep, right? And eliminating pain. So put them to sleep, eliminate pain. Now, if you just go to sleep and I start lasering your disc, you're going to wake up because it hurts. So not only do I have to put you to sleep, but I also have to eliminate pain, because that pain can be so bad during surgery from the laser working near those really painful parts of your disc that you'll wake up from it, okay? We don't want that. So we got to deal with pain, and we usually give something called fentanyl, which many of you have heard about in the news. It's an opioid, very short acting, and we give it in the right doses to treat pain that I'm creating from my surgery. We also give a sedative that puts you to sleep. It's called propofol. And finally, the third part of anesthesia that a lot of people don't understand or think about is amnesia. And amnesia is part of anesthesia. We don't want you remembering anything from the surgery, so we give you some Versed to make you not remember. That's typically what we do. Now, sometimes there are patients who don't respond to those standard anesthetic drugs and they need something more. So we have to give them a little more. Let me have the grabber. Like, for example, we might have to use ketamine, right? And so the ideal patient is going to be comfortable and with good pain control while I'm accessing the disc. And then once I get into the disc, I want them awake for the discogram, feeling able to feel the pain that we're generating with the discogram. Yeah, hold on, I'm not done yet. And then finally, after we do the discogram, I want the patient back asleep, sedated, with good pain control. So hopefully that answers it for you. I think we're done. That looks pretty good. Let's see, maybe just another little bit here. Now, these patients, their discs are never going to look normal, right? We're not here to make her disc look normal. We're here to get rid of pain. That's our goal. Making the disc look normal is not humanly possible. And a lot of these surgeons will tell patients, oh, we need to put a cage because we got to create space. It's all nonsense. They don't need to put a cage to create space. That's what they tell you, to sell you on the cage. But nobody needs a cage, okay? If this patient had gone to other surgeons, they would tell her, I need a grabber. They would tell her, you need a cage, but she doesn't, okay? Cages are unnecessary. How are we doing on irrigation, guys? Good? All right. Thank you. All right, we'll take some more questions.
Next one coming from Ian, once more on YouTube, asking, referring to my previous question, what if I had all my lumbar spine fused, or if my pain follows dermatome patterns that are consistent with the level of fusion I had?
Great question. But basically, we're done with this disc. Basically, if your pain, I have to see where your pain is. And that's the only thing I can tell you, is based on my many years of treating pain, I have to see where it is. But more importantly, I also have to see where there are tender areas. So that Zoom call has to happen. I cannot diagnose you without it. People want me to diagnose their pain source without seeing their back or feeling their back. It's not possible. Nobody in the world can do that. It requires, I'm probably the best in the world at diagnosing back and neck pain, where it's coming from, but even I cannot do it without seeing diagnostic imaging and performing an examination. So I'm not going to guess where your pain is coming from. I don't do that. It's a waste of time. All right. Let's bring the fluoro. Any other questions?
Yes, we have a question coming from Becky on Facebook.
Little pressure here.
Asking, my mom is being offered a lumbar microdiscectomy for 3 herniated discs at L3, 4, L4, 5. Would your surgery be better than this? She's getting extreme leg pain and drop foot.
Yes, this surgery would be far better than a microdiscectomy. Here's why. Microdiscectomy is a surgery that its goal is to get the pressure off the nerve, which is what she needs. However, to do a microdiscectomy, you have to take the bones, normal bone, out of the back of your spine and normal ligament out of the back of your spine. So the surgeon is going to literally drill a hole in the bones in the back of her spine and take those bones out along with ligaments. Now, what that's going to do, it's going to weaken her spine. She'll be back for a fusion, for sure. It's just a matter of when. Nobody wants a fusion. So the surgeons won't tell you you need a fusion right away. They'll tell you microdiscectomy. And then you get that microdiscectomy, and then the patients end up with instability where they did the microdiscectomy and they have to come back and get a fusion or a spinal cord stimulator. Whatever is more profitable is usually what the surgeons or doctors will recommend. Now, the better surgery is what we're doing now, because we're not removing any bone or ligament, normal bone or ligament from the patient's spine. We come from the side. It's called transforaminal. Transforaminal surgery is better than microdiscectomy and laminectomy. But most surgeons don't know how to do this surgery. They're not trained to do it, because this surgery doesn't require metal, not during the surgery or afterwards. So the companies that make metal don't really want the surgeons that are learning how to do surgery. They don't want them doing the surgery because the patients don't need metal. So it's a very corrupt system, and microdiscectomy, I think, is the wrong surgery. I don't even recommend microdiscectomy anymore to my patients. Take it. All right, we're now inside L2-3 disc. Remember, she has a severely curved spine, and it's made this surgery extremely difficult. But the good news is we did verify before we got started that these two discs are indeed causing her pain. Now, the other thing you have to think about, like this patient has osteoporosis, right? You can see the bones are not like the x-ray. The way x-rays work is they shoot a beam of x-ray through the patient, and it hits the bone, and that stops the beam, and it makes it look dark. So when bones are looking lighter than they should, that means the x-rays are going through the bones easily, which means there's less calcium. That's what it means, and that means the patient has osteopenia or osteoporosis. Now, if this patient had a microdiscectomy, and Henry will show you a video on microdiscectomy in a minute, just so you can understand what it is. If this patient had a microdiscectomy, she would require a fusion afterwards, and the screws would not hold in the bone because the bone is weak. So people with osteoporosis like your mother should be very careful about getting laminectomy or microdiscectomy. By the way, there's the herniation right there. I just took out a piece. It was blue. You could see only herniation stained blue. So if it's blue, it must be a herniation. Now, if it's white, it can also be a herniation, but it's very scarred up if it's white. I mean, scar tissue is white, and the dye doesn't penetrate it when it's scarred up. Everything okay out there, Berndes?
There was a question about a brace for the first patient.
God, we talked about it 1,000 times.
I guess the patient neglected to bring it and wanted to go home without it. We said absolutely not, get a brace here. Provide them with a brace here. Is that correct answer?
Yeah, it's fine. So the first patient did not bring their brace.
They wanted to just,
Oh, right. Yeah, she needs a brace. So we just give her another one.
yeah, that's what we're doing.
Huh? But I thought we gave it to them in the clinic yesterday, no? Yeah, the first patient needs a brace. This patient does not need a brace. This patient does not need a brace after, because I've already talked to her about it. All right, any other questions?
Yes, we have a few more questions.
Before we get to them, let's show the audience what a microdiscectomy is all about and why we don't recommend it anymore at Duke Spine. Because it's an old technology that's destructive to the spine. It weakens the spine, destabilizes the spine, and it sets the patients up for more invasive treatments and more pain in the future. We don't want our patients in pain. We want them out of pain. So we don't do microdiscectomy. I would never do a microdiscectomy again on a patient because it is a horrible surgery. It should not be done. It's an old technology. It used to be the best we had, but now we've got a much better way, which is the laser we're doing right now. And I just can't bring myself to do a microdiscectomy anymore because it's so destructive. Go ahead and show them the video.
Playing.
A large incision is made. Muscles are torn from the spine. Substantial bleeding occurs due to muscle trauma. Normal, healthy bone is removed to access the herniation. Stabilizing ligaments are removed in order to access the herniation. An incomplete portion of the herniation is removed. Dense scar tissue forms. Weakened bones can fracture, leading to instability and pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Welcome back. You can see from the video, microdiscectomy is a very invasive treatment. And unfortunately, lots of patients that get microdiscectomies have problems afterwards and need invasive surgery like fusion because that bone removal ends up causing a weakening of the facets. The spine just falls apart, and then they have to have a fusion. Because we're not taking any bone or ligaments out of the spine, nor, you got it?
Yes.
We're not taking any of the normal bone or ligament out of the spine here with our treatment. There is no need for fusion because there's no instability being created. What I can tell you is, hold that for a second, is this patient has, let me try again, really hard hernia. Look at that herniation. It is seriously scarred up, like really firm. Like, we always think of herniation being like crab meat, but if it gets super scarred over many, many years, it's got more scar tissue than normal, and it starts to calcify and become like a rock. And that's what these herniations are. They're literally like rocks. They don't want to come out. They're stuck there. They're scarred in. Oh, look at that thing. They're also dense, meaning they just don't want to float up like normal herniations, right? Normal herniations. But they're dense. They're like rocks. They just want to stay down there. So they're really hard to get out. Any more? So we have more questions, right?
Yes, we do.
Let's take some. I can't even get this out because it's banging against my scope, even though it's a tiny little piece of herniation.
Next question coming from Ian once more on YouTube.
Yeah, of course. Happy.
Saying, also, what if I have a cage and have pain too? What would you do to treat me? I'm sorry for asking so many hypothetical questions. I am a PT, and I've recommended several patients to see you regarding their pain.
Well, first of all, Ian, thank you for that. And I'm sure your patients will thank you. Again, cages don't cause pain ever. So I have to find the source of your pain. It's really about me doing my examination. You'll learn all about it once you submit your MRI for review. Henry, put the link for MRI review.
Copy that, or you did?
Sorry, Ian, I can't be more specific for you, but there's no, I'm not going to guess. I don't ever guess why do people have pain. I diagnose, and guessing is never good. It just creates more confusion, more uncertainty, more misunderstanding, and more suffering. So get a real diagnosis. Just do your MRI review with me. and you'll be very happy you did, okay? You'll be very happy you did. All right, just about done. I've got about, 20 seconds left. No, sorry, 1 minute left, and we'll be done. She's doing really well. She's sleeping. She's comfortable. We have had no issues with her. She did take Celebrex for a long time. Celebrex is an anti-inflammatory, and it impairs your platelet function. So she had a little more oozing than we're used to seeing, but by God, everything went really good. Very happy for her. Any other questions?
Yes, coming from, I love the name, Lord Impaler on YouTube,
Oh, nice. Welcome.
asking how likely is it for an insurance to pay for this procedure if you live in another state? I have cervical C5, 6, and 7 that need to be worked on due to a car accident. Workers' comp may not pay.
Sure. Great question. There are thousands of different insurance plans, even Blue Cross Blue Shield. Anthem has thousands of plans. Every plan is different. Some have great coverage, some have horrible. It's impossible for me to predict what your insurance will do. But if you have out-of-network benefits, you have a much higher chance of getting it paid. If you don't have out-of-network benefits, you have a much, much lower chance of getting it paid. So out-of-network benefits are usually pretty good. That said, we won't know until we talk to your insurance, look at your plan. More importantly, we got to know what you need done, right? So just really depends on what needs to be done. All right. Any other questions?
At this moment, no current questions.
Thanks for joining us. You can see I had to make 2 small cuts. Normally I can get the 2 discs with 1 cut, but because of the angle of each disc, because of the scoliosis shifting the angles of the disc, I had to do 2 cuts. But they're 1/4 inch each, and she did great. Remember, she has osteopenia, osteoporosis, I don't know which one, but she has some bone mineral deficiency, and I can tell you right now that thank God she didn't need screws and rods, because they wouldn't have held in her bone. They would have just pulled right out. All right, thanks for joining us. We've got more surgeries coming up. Is the next one in room 2? So we'll be back in an hour, because the next one is in room 2. Oh, look at this piece of herniation right here. You see that, Henry?
Yes, we do.
Yeah, that's just one of the many pieces we took out, but it's a good size one. We do place staples. We get these things out the next day, so they just stay in overnight. And she'll be sore for the next couple hours, but once she wakes up, she'll make a full recovery. You can see the herniation right there, right? That's just one of the pieces we took out. All right, thanks for joining us. Why don't we leave our audience with a nice, one of our patient experiences who came here and had surgery. Henry's got lots and lots of those. Thanks, everybody. Great job. We'll leave you guys with a testimonial from one of our surgery patients. MRI review. And good morning. It is now March 6, 2024. I'm Dr. Dumajan, and I'm here with a patient of mine who wants to share her story. She had a back injury. She had a herniated disc, and it was pinching the nerve going down her leg. And I'm going to let her tell you more about it. But just yesterday, 12 hours ago, she had the Duke laser disc repaired, L5S1. How do you feel today?
I feel amazing. It's literally a day and night transformation. I was bedridden since December up until the day that I came and did the surgery. I had it yesterday. The relief that I felt after the Duke laser disc repair, it's day and night. I'm walking. Like I was able to, do my hair and, fill in my eyebrows and, maybe that's too much information, but,
You're
get ready.
smiling.
Yeah, but get up smiling.
You were not smiling
I was not
when
smiling
you first
yesterday.
came here. So.
No, I was so miserable and I'm so grateful that you do what you do. And if, oh my gosh, I'm so grateful. And I feel like my prayers have been answered and I'm so happy. I'm so happy.
Now, you came far away. You came from Pennsylvania to Florida for the Duke laser disc repair. Why did you come so far?
I wanted to get surgery because I felt like everything that I've tried, the physical therapy, the chiropractor, the pain medication, it wasn't helping. I was even doing like at home stuff, more conservative treatments with the McKenzie workouts. Nothing would alleviate my pain. And I saw the surgery that was out there, the opening of the backs and just a different type of surgeries. And too, like my father has back conditions and he told me about his experience when he had his fusion and how it took him months to recover and to get better and he wasn't able to move. And I said, there's no way. I have 3 kids. I have to be a mom and I have to take care of my house and, not depend on everybody else to do things for me. To be honest, I was Googling another chiropractor on YouTube. Dr. Duke's video came up with a testimony and I decided might as well watch it. I'm watching everything else, right? So I watched it and I couldn't believe, I was like, wow, is this really real? And then I started watching the surgeries because he does the surgeries live and, hearing Henry and hearing Dr. Duke. And I love the entire interaction with answering questions. I was able to even ask questions during the live feeds. And I was convinced that this is for me. I'm next. I'm going to sign up and I did the MRI review.
And I'm smiling because it's really special when one person's testimony or sharing their experience, and now here you are, you watch theirs and now you're giving yours because they helped you to see the right path, right?
They did.
You're crying because you've been in pain and suffering for so long, right?
Too long.
Nobody should suffer like that. Get it fixed and get it fixed the right way. Do you feel you made the right choice coming to Duke Spine?
Absolutely. Absolutely.
If you had to do it again?
I would do it again. 1,000%.
Well, you're not going to have to do it again. Right? You're going to follow the instructions and you're going to have a great life and not have to worry about your back anymore. Go take care of your kids. Okay? You're welcome. It's my pleasure. My pleasure. You're welcome.
This is the right doctor. If you have back pain, this is the right doctor. He will fix you.
We have a great team here at Duke Spine.
They
and
do.
We love what we do. And we love this right here. We love getting people their life back. That's why we do it. It's the greatest gift in the world that we could ever have. Thank you for sharing it.
Thank you.
Thank you. All right. Come on, let's get you out of here.